Okay, thank you everyone for joining us on this Valentine's evening. We do appreciate it, whether you're staying at home for some self-love or you guys are going to be going out afterwards. We do appreciate you taking the time to join us for this female reproductive health webinar. And then we're going to have a lovely portion on how to keep the spark alive whilst trying to conceive. Dr. Antonio Rodriguez, I'm sure most of you know who he is. Dr. Rodriguez is a reproductive medicine specialist who co-founded MedFem Fertility Clinic. He is an expert and leader in minimally invasive surgery. He has a special interest in time, urgency, perfectionism, stress, and its influence on fertility. He also co-developed an online self-help interactive stress management program and has published internationally and co-authored chapters in books in the field of hyperinsulinism in male fertility and stress and its role in infertility. There's always one word that catches me out.
Thank you.
Thank you, Dr. Rod, and thank you, Mandy, for coming on this Valentine's evening. We appreciate it.
Okay.
No, absolute pleasure. We're lucky that we're married, so we can spend Valentine doing this talk with you. Yeah, so what I thought of, I'm not going to put up slides and things. I'm just going to keep it relatively informal and just as if we sitting with a patient and going through the journey of infertility. I think the first important thing anyone presenting to a fertility practice needs to understand that they have to go through a series of investigations. And these investigations aren't that extensive. We look at hormonal profiles, hormones like thyroid, insulin, prolactin. We look at egg reserve levels. In our practice, we like to also check patients for immunological problems because about 15 to 20% of our patients have a couple of immune diseases, such as antibodies against their thyroid and anticardiolipins. These things are all important, so we like to check things right at the beginning. And on the male side, we do similar testing. They have blood tests. We check their insulin, we check their prolactin, and we check their thyroid levels. And also in men, we like to check their FSH levels to make to try and diagnose if they do have a sperm problem, why they have a sperm problem. And we do these things right at the beginning. I think the other message is this is a team effort. I mean, you need sperm and egg to make a baby, so the couple need to be on that journey together. And in terms of the male, what often comes up, depending on certain thought process, sometimes cultural thought processes, people are a bit reluctant to do semen analyses. In our particular practice, we won't see a couple unless the sperm is tested. It's no use focusing on a female and 6 months to a year later, you find out that the male's got no sperm. So we do all these tests actually preferably before patients come to see us on the first visit. And then when you see us on a first visit, part of it is taking a history, finding out what's happened before, if there has been previous infertility management, where it was done, what happened, what was the outcome of it. And then lastly, in that first visit, we always do a vaginal scan on the female. Very important tool for us in terms of IVF management. Our transvaginal scan does all the work. Very accurate in looking at the uterus, in looking at the abnormalities of the uterus, in looking to see whether the hormones are acting properly on the uterine lining, and importantly, look at the size of the ovaries and making sure that there's no diseases of the ovaries. And that we do literally in one visit. So often after one visit, if all the tests were done before, one can make a very a primary diagnosis of all the problems that are there. And again, in the group of patients we see, and just to put that in some perspective, most of our patients are professional males and females, and they are working couples. They have very specific diseases. And on that first visit, we often can identify the problems that they present with. On the female side, we see a lot of patients with underactive thyroids, on their subclinical underactive thyroids. High insulin levels are a very, very common problem, both in males and females. And this is a lifestyle problem. It's related to dietary issues, especially excessive carbohydrates in the diet. And just to bring it right in the front of this talk, it's very important for couples to realize that if they can, they should focus on a healthy living during this whole process. The healthier you are, the more focused you are on lifestyle issues, both dietary and stress, then the better the outcome, the time to pregnancy is quicker. And again, at MedFem, we focus on this issue called time to pregnancy. It is our intention to try and get someone pregnant as quick as possible so that they don't have to go through the whole trauma of long-term infertility management. Some couples, unfortunately, have to go through a very long journey and they have very specific problems. On the male side, just to bring the male into it, a semen analysis consists of producing a sample by masturbation, and that sample is then assessed for a whole lot of factors, including how many sperm are there. There needs to be more than 10 million sperm to be normal. Sorry about the dogs, but they don't know that we're sitting on this talk. So if we look at the male side, there we go, they're quiet now. If we look at the male side of it, in terms of, so I said the count of the sperm, the secondary thing is the motility. Motility means how does sperm move, and that needs to be more than 30%. We look at something called morphology, which is the number of normal sperm per 100. A male sperm is mostly abnormal. To be classified as a normal, it's 5 to 10%. If it's below 5%, it's abnormal. We then look at the ability of the sperm to bind to an egg. And just to explain what that means, everything might be fine in terms of the count and the motility and how the sperm looks in terms of normality, but it might not have an ability to bind to an egg. So we do that as a primary test in our practice. Once we've got this first visit over, we then tend to go through what we call a cycle assessment. We check that the ovulatory process is right, that the physiology around the uterus is right. And in our practice, we play a big role on mucus, of the cervical mucus. It's probably the biggest cause of infertility in our practice, and obviously there are associated factors with that. So we do a test where on the day of ovulation or just pre-ovulation, the couple have intercourse in the early morning, and when we do a scan, we also do a little sample from the cervix, and we check that the sperm is alive. We found over the last 30 years that I've been doing this, that every patient that has poor mucus will have underlying endometriosis as well. So again, in this primary visit with a patient, we know two things. Could they have endometriosis? If the mucus is poor, we, in our practice, close to 100% of patients will actually have endometriosis. And in terms of the scan, we can see on the scan whether that ovary is normal or whether there are what we call polycystic ovaries. I'm going to focus on polycystic ovaries and endometriosis for the rest of the talk. And the reason that I want to do that, it's probably the commonest things that we see in our practice. And I say our practice because it's this group of patients who have a very low incidence of tubal disease. Yes, sometimes the male has other severe problems, and that's got nothing to do with lifestyle. But mostly the patients have diseases such as, well, the female polycystic ovaries and endometriosis. And in the male side, the commonest problem is that they have a low number of normal sperm. What is this term polycystic ovaries? The first important thing is patients with polycystic ovaries usually have a very high AMH level, and that is an anti-Mullerian hormone. It's a measure of the egg numbers in simple terms. It's not a definite figure, so we can't go and say the AMH level is 1 and 1 is 1. It does vary, but it gives us as fertility specialists two things. It tells us what is the lifespan of that ovary in terms of time. You could have a 25-year-old with a very low AMH. That person doesn't have a long time to produce eggs. I also would like to bring in here, if you've been told that you have a low AMH level, it doesn't equal that you don't have good eggs. When you read this stuff on the internet, it looks like they are 100% associated. A low AMH means you have low number of eggs. Does it reflect on egg quality? Age reflects on egg quality. A 25-year-old with an AMH of 0.5 will have a chance of falling pregnant, whereas someone who's over 40 will have a reduced chance because they don't have a lot of eggs left. And as you get older, the quality gets worse. So I just want to bring that in. In terms of polycystic ovaries, the patients usually have high AMH levels. And just what does this polycystic ovary mean? When we do an ultrasound, the ovary looks like it's full of small cysts. If it's a severe case of polycystic ovaries, those women actually don't have any periods whatsoever. And you get two groups in that. One, the normal weighted to underweighted patient, and on the other side, the overweight patient who's struggling with their weight in terms of being a very high BMI level. The same condition, what you read is it always sounds like you have to be overweight, you have to have a lot of the symptoms such as increased acne on the skin, increased hair growth. There are patients without any of that, and they are underweight and they've got polycystic ovaries. So again, just to explain what happens in a normal cycle, when the period starts, there are around about 20 to 30 eggs available for that particular ovulation. And in women who have polycystic ovaries with very high AMH levels, they can have 50, 60 eggs available for ovulation. And you can imagine that in reality, the physiology works in such a way that the dominant egg, the one that's going to actually be released during that cycle, will have difficulty in getting rid of the rest of the eggs. So there's this competition between the dominant egg and these very high volume of other eggs, and that dominant egg struggles. So some women, it won't actually develop at all, and it will keep recruiting new dominant eggs, but it cannot win the fight, and you'll end up with no periods. Other women have irregular periods that are longer, 32, 35, 40 days. And then you get a group of women who actually have more a multicystic ovary. They have the same problem where the dominant egg is struggling to get the other eggs inhibited. And in fact, they basically kill off the other eggs. And because of that, the ovulatory process is not perfect. They're all the same condition. And we can diagnose that very early. In fact, on that first visit, we can actually come up with that diagnosis. In our particular practice, if patients have poor mucus, we tend to put them through a laparoscopy. And the reason we do that is we want to diagnose endometriosis. And at the same time, we will check the fallopian tubes. We'll put a camera called a hysteroscopy into the uterus and check that the uterus is normal internally. We would have known from our scan whether there are any things like fibroids or polyps or any other growths in the uterus, and we'll fix it at the same time. And lastly, we will then manage the endometriosis by getting rid of the endometriosis tissue. So when that patient then, after that operation, one can then make a decision to go forward. What is important is, why does endometriosis occur? A lot of people wonder why they get endometriosis. So let's look at it. First of all, what do you need to get endometriosis? You need to be having periods. So that's menstruation needs to have occurred. If someone's not menstruating, so a polycystic patient who doesn't menstruate at all has almost a zero chance of having endometriosis because they are not having menstruation. Importantly, during menstruation, the blood from the uterus not only comes out vaginally, but goes down the fallopian tube. And in this blood, there are what we call endometrial cells. And these endometrial cells go to lie in the deep pelvis. The little fallopian tubes are pointed downwards. They drain into the lower pelvis. And if the immune system doesn't clear those cells in a very predetermined time, the body recognizes the cells as something that should be there. Another immune system kicks in called the cellular immune system and allows these benign tumors of cells that look exactly like menstrual blood to grow in the abdomen. And there are varying degrees. Can be stage 1, 2, 3, or 4. Stage 4 is severe. And again, from our point of view, when someone's trying to have a baby, we don't focus on the stage 4. We focus on, if we're doing an operation, we focus on managing the endometriosis to improve outcome with future fertility. In terms of your polycystic patients, just to go back to what can we do for them in terms of treatment. The general feeling is if the patient has, we will always try oral therapy to help ovulation. And the drug we mostly use is Femara, letrozole, and we sometimes add in half a clomiphene. Clomiphene or Clomid in high doses is not a good practice for polycystic ovaries that are severe. There's a twofold reason for it. One, it often won't work. But the other thing is if you're not being monitored and you're taking these drugs, you can land up with multiple pregnancies, number one, or overstimulation from having high doses of those drugs. If we can't get an ovulation in polycystic ovaries with clomiphene or Femara or the two together usually, if it's severe, then we will use injectables such as FSH or FSH mixed with LH in low doses. And in that group of patients, if you cannot get ovulation, a certain number of them will end up with in vitro fertilization, because with in vitro fertilization, it doesn't matter if you make 15 to 20 eggs. We can control the environment. The eggs are removed. And we feel strongly about generally putting one embryo back to limit the risks of multiple pregnancies. So I don't know if there are any questions at this stage. If there are, I'm happy to take them. We
do have a question from a male attendee. What steps would you recommend to restore sperm count after coming off TRT due to a diagnosis of hypogonadism?
So the big thing there was the diagnosis due to complete testicular failure, or was it actually, or was it due to taking testosterone? So if you've got complete testicular failure, in other words, if the diagnosis was that there was a problem with the testes, which is usually a genetic problem, then at the beginning of the treatment, the doctor would have found that the FSH levels and LH levels were very high, telling us that that patient's pituitary is working fine, but there's no activity in the testes. That particular patient will tend to not be able to recover that because there's actually a primary problem in the way the sperm forms. Having said that, a lot of patients we see have been given some form of testosterone. There's a bit of a tendency to give younger men testosterone without, well, I'm not talking about sort of recreational, you're going to do gym, etc. I'm talking about doctors giving it where the patient complains of tiredness, they do testosterone levels, they're low, and then they start giving them testosterone. Importantly, one dose of something like Nebido, which is a 3-monthly dose, will act like a contraceptive. It will take away the pituitary function, and after 3 months, that person will need to either have a top-up, and generally the sperm count will go down to nothing. We can get it back to normal in most patients, but it does take treatment with stimulation of the testes with the same medications that we use in the female. We use FSH and LH, and we use HCG to recover it, and we use Fertimed or clomiphene to add to it, and we put all our patients on Stamina Grow in that case. So it does depend on the diagnosis all the time.
Okay, thank you, Dr. Rod. And what age does endometriosis tend to develop?
So in the patients we see, the majority of them don't have, and I think that it's a good question, because it brings me to a factor that says, when you read about endometriosis, it says you must have pain with intercourse, you must have pain with your periods, you could have blood in your stool, blood in your urine, you have pain with ovulation. That in our fertility practice, which is big, the pain side is very rare. 90% of people don't have any of those symptoms. So when in their minds they believe that they're fine. But if their mucus is poor, 100% of them have some form of endometriosis. And from our experience literally over the last 30 years, if someone has a few spots of endometriosis and nothing else wrong with them, fixing that can make them fertile and give us a baby. So it can occur from any age. When we were doing general gynae, and we were the first people to do, or one of the first groups to do laparoscopic work in this country, we saw a lot of younger women at that point in our careers, and there were women in their 16, 17, 18 with endometriosis, but they were presenting with pain. And that's a very specific group of patients, and they might have there might be a genetic element in them that it can be passed on. From my point of view and Mandy's point of view, we believe that it is a stress-related condition. Not that stress causes endometriosis. Stress changes the immune system to allow those cells to grow in the abdomen. And that's what we believe in. And again, Mandy might be covering that a little bit. Having said that, again, when we talk about stress, it's not to make people more stressed, it's to give them some options in terms of how to manage themselves.
Thank you. We also have a question from a person that's got PCOS, a woman's got PCOS. According to my gynecologist, the pH of my body causes the sperm to die before reaching the egg. We already did one cycle of artificial insemination with Femara. Is it worth trying another cycle?
So I'm assuming that the gynecologist physically checked the mucus at the time of ovulation to make that diagnosis. Again, if the mucus is poor from a fertility specialist point of view, bypassing the mucus with artificial insemination can be tried for a couple of months by a gynecologist. Having said that, the problem with it is that it is related to endometriosis. So we would tend in a shortest period of time to go and look for endometriosis and fix it before we do multiple inseminations.
Okay, great. And then there's another question. Hi, doctor. I would like to find out if there's an alternative to IVF if a patient can't afford it and the patient was diagnosed with endometriosis.
So importantly, if you get all the little things right in a patient, often you don't need to do IVF. So again, our step-up treatment at MedFem is we will check that patient and see why they're not falling pregnant. If all the parameters are normal, such as there's no hormonal factors, the sperm is fantastic, ovulation's perfect, and the mucus is perfect, then that group of patients often need a jump to IVF because there's no cause. But if you find a cause, and she's obviously had a laparoscopy, the patient, then one can try and improve mucus with medications such as Menopur, which is an FSH. Unfortunately, repetitive inseminations in this group of patients has a poor prognosis if there was a primary diagnosis of endometriosis. And again, I think it's important to know where you stand as a patient. If the only treatment for you is IVF, don't waste your time and money on other things, rather save up for IVF. But by the time you do 2-3 inseminations, you would have paid for 60-70% of an of IVF. So I think, it's important to have that specific treatment and do it when you can do it, rather than waste a lot of money on things. But a lot of patients fall pregnant with endometriosis post. Yeah. Oh yes, and Mandy mentioned, we did a study. As you know, we've been doing, Saskia, we've been doing work on stress for now 25 years. There's no question in my mind that stress management improves prognosis in endometriosis patients, to the degree that a lot of patients, while we were preparing them for IVF, have fallen pregnant in the past, because then you heal yourself. The immune system changes. And we're talking about a very functional stress management program, not something where we're looking at when the patient was a youngster and what happened when they were 5 years old. Okay.
Excellent. Yes, and Mandy, you're gonna tell them where they can go and find that stress test just now.
Yes, I will.
Okay.
I will. Thank you.
Dr. Rod, you've got a couple of minutes left. Long-lasting treatment for endometriosis. Is it just a matter of ongoing laparoscopies, or is there a treatment that they can be on to help their embryo?
So if you're doing infertility treatment, we sometimes do short-term inhibition of the endometriosis, usually these days with a medication called Vizan. But it's really just a holding thing to get rid of acute inflammation, and then move to IVF, if we have to, obviously. And then long term, if the person has completed their family and they have severe symptoms, then one can go on to something like Vizan for years. Obviously, endometriosis will burn out as soon as periods stop. As soon as that woman becomes menopausal, it'll be done.
Okay, and I don't know if you can see the question in the Q&A.
I can see that.
Okay, I'll read it out for everyone else. I was diagnosed with adenomyosis and severe endometriosis, and also one of my tubes has some liquid. I was advised at the clinic I went to that I should first operate to remove the fallopian tubes, then go for IVF. I saw another specialist who didn't think I need to do the operation and can do IVF. I'm 41 years old. I'm just confused at the moment. IVF is extremely expensive and clinics don't offer payment plans. I just want to know what to do next. As much as I know there's no guarantee that IVF will work, I didn't know you could remove endometriosis tissue. I have medical aid but can only upgrade in December, and I turned 42 at the end of the year.
Yes. So importantly, from an adenomyosis point of view, which is like having endometriosis in the muscle of the uterus, that you can't remove because it's in the muscle. If you start cutting that away, you're going to damage the uterus. With that condition, it's very important from our point of view, to see whether that the area where the baby would form is not being affected by the adenomyosis. In terms of the laparoscopy, you definitely can clean up endometriosis, and with this sort of picture, we would always want to clean that up before any treatments. I'm not sure if both the fallopian tubes, it sounds like one of them is a problem. But if you do have blocked tubes where they're actually totally blocked, unfortunately, that fluid in the tube kills off the embryos. If it's one side, the tube should be removed. If it's and in fact, if someone's got one tube that's blocked and the other one's open, often it happens that if you actually take out the tube that's blocked, there will be a spontaneous pregnancy. So I think in terms of what are options for you, you can get your endometriosis sorted out. There are payment plans in terms of companies that will give you a 6-month period, even up to a year period of credit, so that you can do your IVF. So on our website, I think they are listed on our website, or our practice can give them that information. So there are ways of doing it. I understand this patient's predicament. She's turning 42 at the end of the year. to wait to upgrade her discovery plan doesn't make sense.
Okay. Yeah, no, I agree. And then if you're diagnosed with endometriosis stage 4 after surgery where it was removed, do you still have stage 4?
So it does depend a lot on what was done at the time of the operation. If it was stage 4 for severe pain and a lot of cutting was done, then that stage might be, depending on what the doctor says, reduced after the operation. It's very patient dependent that. Our treatment of stage 4 is to clean up the endometriosis to do IVF. We don't do aggressive surgery because that can lead to reduced ovarian function. So we do a cleanup in order to improve IVF. Those patients usually need IVF.
And then that depression one will pose to Mandy. And then it's the final question: was my PCOS related to my miscarriage?
So the commonest cause of miscarriage is related to poor eggs, and poor eggs lead to abnormal embryos. That's the commonest cause. PCOS patients definitely have a higher incidence of that. The reason that happens is there's often a delay in the way the egg develops. High insulin plays a role. They often have coexistent thyroid and prolactin problems. So back to all those first tests I said that we should do right at the beginning. If you control all of that, control the insulin, get lifestyle right, you can optimize your eggs and have a better chance that you're going to have a healthy embryo. So a healthy embryo can only come from a good egg, and the better that patient and the effort you put in. And if I can give all of you just one message tonight, put the effort into your lifestyle. You don't have to go overboard. A balanced lifestyle and managing both stress and diet, and obviously things like alcohol, smoking,
Vaping.
drugs. Yeah.
Vaping.
Yeah, vaping, I think vaping, nicotine's nicotine. It's an arterial, causes spasm of arteries, whether you're taking it in cigarette form or you're taking it in vaping, same problem. It's going to give you the same.
Okay, great. Thank you, Dr. Rod. If anybody hasn't asked their questions or they want to, you can also revisit it at the end. So you're welcome to type your questions in the box still. Thank you. Thanks, Mandy. Thanks, Dr. Rod. We'll post this on our YouTube channel and MedFem's YouTube channel next week once we've managed to edit a bit. And we'll put it out on all the channels when the video goes live on the channel. So please follow our Facebook page, follow MedFem's Facebook page, follow Mandy, and just Mandy gives out some really interesting information every week of how to deal with your mental health, and as does MedFem. So it's worth following all of those channels. So have a lovely
Saskia. We really appreciate everything you do for the patients and for us. It's fantastic.
Yeah. I echo that.
Yeah.
Thank you.
Thank you. It's a huge pleasure. Bye, guys.